Hello again, everybody, and welcome to another edition of Doc Talk with Monument Health. My name is Mark Houston, and back. I always like having you guys back because now I can kind of judge your comfort zone with me. And Dr. Issam Turk, you've gotten even more comfortable, so I appreciate that.
Yeah, I'm super casual today. That's how comfortable. I almost came in a bathing suit. But,
it's nice enough today to
it
do
is,
this.
yeah, exactly.
You, of course, are a gastroenterologist at Monument Health. Last time we talked, episode 86, you and I talked about diverticular
disease.
Yeah. It's a super fascinating podcast to go back and listen to. It's something that even though I've suffered with it for 20 plus years, it helped me out. You had some great information in that podcast.
You're welcome. You still haven't Venmo'd me.
Well, I didn't have your Venmo, so it's a little on your end too, right. I guess, Doctor.
I'll cut you a deal. Don't worry.
So today, we'll get into another one of your specialties. And
Sure.
And as we were talking earlier before you came in, you said this is the big one, the IBD.
It's very complex, absolutely. I mean, when it comes to IBD, Inflammatory Bowel Disease, it is a very complex GI disease and group of different diseases. And again, if we go deep into it, we could go on for hours and hours and days. So, I mean, it's just, it's also one of those very tough diseases where there's levels to it, right? So, you could have mild disease, moderate, severe, and then when it's severe, it could be destructive to a patient on many levels. I mean, internally, GI-wise, physically, psychologically, mentally. And then we'll touch base on it today as much as we can,
Sure.
And in a way where I try to break it down into layman terms because, like I said, it's in terms of gastrointestinal diseases, it's one of the most complicated and complex and harder diseases to understand.
Why is it so hard to understand? It seems like, the food goes in, the food goes out, right?
Yeah.
But that process in between must be
Exactly.
ridiculous to understand.
So that's the thing. I mean, the GI tract in general is very fascinating, right? I mean, yeah, you can look at it. It's as simple as you eat food, then it comes out as poop.
Right.
But there's so much that goes on in your GI tract, from your mouth to your esophagus, to your stomach, to your small bowel, to your colon, out the gun. But in between, there's, the digestion that's happening and the different enzymes. And then, the pancreas is playing the role, the liver is playing a huge role, the small intestine is playing a role. Every part of your GI tract is playing a very, very key and important role that cannot be replaced. I mean, probably the most I don't want to say useless, but out of all the organs in the GI tract, the two that I guess that can be spared are the appendix, which isn't even really an organ, it's just an extension of the cecum and the colon, but like the gallbladder, right? I mean, the gallbladder, when you end up, we're deviating off topic, but it's just a little side thing. But,
Sure.
When gallbladder, you have gallbladder disease or gallstones and you need your gallbladder out, it could be removed and you'll live a normal life. But you could also have side effects, right? Because
Right.
the gallbladder is there to store bile. Bile is made in the liver. And then when you have a gallbladder, whenever you eat something with fat, then it's getting secreted in an incremental fashion to help emulsify and help with fat digestion, the breakdown of fat. When the gallbladder is gone, the liver is still making bile, but instead of the bile being stored in the gallbladder, now it's just getting readily released. And with it comes diarrhea and then bloating and something called post-cholecystectomy syndrome. So, the point of this side story is something like the gallbladder, which isn't that key, or that removing it could result in some issues and discomfort and inconvenience and stuff like that. And but every other aspect or part of the GI tract is very important. And today we're gonna focus on the intestines.
Okay.
And that's basically where IBD happens. So IBD stands for Inflammatory Bowel Disease, not to be confused with IBS.
Does IBS fall under IBD, or is it a whole other thing?
It's a whole different. So IBS is Irritable Bowel Syndrome. So it's a disorder where basically, and then that could be a whole topic. That could be a whole other session. But basically, just briefly, IBS, Irritable Bowel Syndrome, it's a disorder where a patient will have a variety of different GI symptoms such as bloating, cramping, it's intermittent, it comes and it goes, diarrhea, constipation, change in bowel habits, but really no actual inflammation, no actual organic cause, no actual infection, right? So that's why it's a syndrome. And there's 3 different kinds of IBS. There's IBS-C, which is Irritable Bowel Syndrome with constipation. So it's constipation predominant, where the patients are having the bloating, they're having the pain, they're having the cramping, it's intermittent, and then they're constipated. And then there's the IBS-D, which is IBS with diarrhea. So basically all those symptoms and diarrhea. And then there's the most annoying one, which is IBS mixed subtype, because they're alteration between diarrhea and constipation. That's one of the harder ones to treat because, as opposed to other diseases or infections, usually you have a solution, right? Mm-hmm. Now with IBD, inflammatory bowel disease, Crohn's and ulcerative colitis, there's no cure, but there's treatment. Okay, there's a pretty good treatment right now, especially with infections. We know you treat infections with antibiotics if it's a bacterial infection, like diverticulitis last time.
Right.
But with IBS, with the syndrome, there is no clear-cut answer, right? It's not like, oh, okay, take some fiber, you're fine. No. Every case is different. And then there are patients that are miserable and they're in and out of the ER and they have such severe attacks and pain and spasms. They feel like they're dying. They're in and out of the ER. They get CAT scans. There's nothing. They go this. So basically, IBS syndrome varies between diarrhea, constipation, or alterations of both, and then bloating, pain, cramping, and then you just gotta find, and then maybe we'll do another topic on this next time so we could break it down and talk about the diagnosis, which is mainly, it's a diagnosis of exclusion. You rule out other things, and then you end up with IBS. You don't scope everyone with IBS unless there's alarm features, and we would talk about it next time. But you just gotta take it case by case. There is no clear-cut solution or treatment to something like IBS.
Okay.
Everyone presents differently. There's different severity. There's different presentation, and then depending on, it's an individualized basis how you approach IBS.
So then the IBD, which is kind of what we'll focus on, that's like you said, we started this whole thing. That's completely different.
Oh yeah.
And there are 2 main ulcerative colitis and Crohn's are the 2 main ones that fall under that most people would know of.
Yes.
Okay.
So. And by most people, it's really going to be people who are affected by it, right? Because if you don't have Crohn's or UC, you maybe have heard about it. Or if you have a family member that does, then you know about it. Or if you have it yourself, then you really know about it, right? Otherwise, I could guarantee you that the average person has no idea what Crohn's is, what UC is. Although it's quite common. I mean, 1 in 100 Americans have IBD.
Wow.
Yeah, I mean, right now it's 3.2 million, I believe, in this country that have IBD. So Crohn's or UC, or the third kind, which is indeterminate colitis, which is basically kind of like a vague area where they have features of both and it's unclear. So let's talk about, forget IBS for now. So IBD is a real disease. Not that IBS is fake.
Right.
IBS is more a brain-gut connection and the symptoms are real, but it's not a truly organic disease where there's an inflammation. It's not inflammatory, okay? So IBD is real. There's 2 kinds. There's Crohn's and there's ulcerative colitis. And then there's the third one, which is indeterminate colitis. I'm not going to get into it. It's just confusing. But we'll focus on Crohn's and UC, which are the 2 most common kinds. So with UC, as in the name, ulcerative colitis. So ulcerative means that there's ulcerations. Colitis means inflammation of the colon. So just like the name, it's affecting the colon, which is the large bowel.
What is an ulcer, really quick? Just to define that a little.
Yeah, so when you talk about an ulcer, it's an irritation or an injury to a layer, right? So you can have diabetics get ulcers in their feet where basically the skin starts getting broken down and then it starts eroding and then you go that ulcer in your stomach. The mucosal layer of the stomach starts kind of eroding downwards and then you expose deeper tissue, and then you could bleed. And then if you go all the way through, transmural, through the whole lining, then you end up with a perforation.
Got it.
So an ulcer is basically like a deep cut. That's the best way to put it, right?
And with UC, it's in your colon.
With UC, exactly. It's ulcerative colitis, so it's deep cut or cut affecting the colon. Now, as in the name, it's just affecting, so colitis, it just means the colon, itis, inflammation. So there's ulcers in the colon. And with UC, the disease is just confined to the large bowel, the colon, which means from the rectum all the way up to the cecum. So that's how your colon goes. Remember, colon goes cecum, ascending colon, transverse colon, descending colon, sigmoid colon, rectum, and then anus, right? So with ulcerative colitis, it's ulcerations that's affecting the colon, and then there's different kinds, right? With UC, it could be ulcerative proctitis, which means it's affecting just the rectum, so the lower part. There's left-sided colitis or ulcerative proctosigmoiditis, which means it's affecting the rectum and the sigmoid colon, lower part of the descending colon, so it's on the left side. And then anything beyond that, then it's called ulcerative pancolitis, which means the entire colon. And with ulcerative colitis, basically it's affecting the mucosal layer of the colon. So if you think about the inside of the colon, so it's the epithelial layer, it's the inside layer of the colon, and it's not penetrating all the way through. So as opposed to Crohn's, where it's what we call transmural injury, where it could go through the entire layer of the intestine. So with UC, it goes colon. It always involves the rectum. Okay, almost always involves the rectum, and then different levels of the colon, and it's just the mucosal layer. So that means it's the inner layer, and not too deep, not all the way through, and basically it spares the small intestine and everything else. Crohn's, on the other hand, that's why it's called Crohn's disease, as opposed to like ulcerative enteritis. Right? So it could affect anywhere from the mouth to the anus.
That
literally
is fascinating, because I had no idea that it could start up where you
that's
chew
all
and swallow.
part of your GI tract, right? So Crohn's can literally affect anywhere from your mouth, so mouth, esophagus, stomach, small intestine, duodenum, jejunum, ileum, all the way down to the colon, and it usually spares the rectum. But there's cases where there is rectal involvement, and there's that one big where it's indeterminate, where it's like unclear. So there's sometimes where it's clear cut, it's UC, sometimes clear cut, it's Crohn's, and sometimes it's like, this is, I don't know, features of both. So with Crohn's, it could affect the entire GI tract. Most of the time, it's affecting the lower part of the small intestine, which is like the terminal ileum, and like part of the colon. And with Crohn's, it usually, like I told you, it goes through the entire, it's transmural injury. So that means the ulceration can go all the way through. So not just the innermost layer of the colon, it could go all the way through the whole lining of the intestine. And it goes in, it's called skip-like fashion. So it could skip. So with UC, it goes either proctitis, so just the rectum, or left-sided, where it's like the lower part of the left, or the entire colon. And it just goes in a continuous fashion. With Crohn's, it's in a skip-like fashion. It's actually very fascinating. Like when you scope a patient, you go in, it's like, all right, rectum looks good. You go to sigmoid colon, deep cratered ulcer, then it looks good. Then you get to the transverse, deep ulcer with bleeding. Then you get to all the way to the right side, nothing. And then you get to the cecum, you see just like bleeding, inflammation, abnormal tissue, mucosal bridging, all these just angry-looking tissue, and then you try to get into the terminal ileum, which is the lower part of the small intestine, and then you just see ulceration there. So it just goes, it skips. It's called it's skip lesions or skip-like fashion, and that's how Crohn's disease is. Now, in terms of symptoms, they both will have diarrhea, change in bowel habits, but as opposed to IBS, they're having, fevers, bleeding, really bad abdominal pain. With Crohn's disease, it's mostly a lot of like distension, high fevers. They develop abscesses sometimes, bowel obstructions. They could develop something called fistulas, which is specific to Crohn's disease. You don't see that with UC. Fistulas are basically abnormal connections that form. Now you can get, and that happens as the result of ongoing unchecked inflammation. This is the patient that's been having symptoms, who's been writing it out and is not seeing anyone. Next thing you know, they're peeing poop. I'm not even joking.
Oh my goodness.
Or a female and there's stool coming out of her vagina. That's like enterovaginal
Just
fistula.
because it's made a different path.
Exactly. Because remember what I said, with Crohn's disease, the injury is transmural, so it could go through the entire lining, so the lumen all the way through, and it penetrates, right? So then because there's inflammation, then nearby structures or organs, or from a colon to small bowel, or from the colon to the vaginal canal, or from the colon to the bladder, or small, then connections form. It doesn't happen overnight.
Right.
This is just chronic inflammation. And you can even get that sometimes with complicated diverticulitis, right? Patients who've had so much, because it's inflammation, right?
Yeah.
Then just things start they connect to each other, and then they form. And that's how a fistula forms. And that's ugly. I mean, those patients, literally, I've had patients where they're peeing stool,
Right.
or females where
Right.
stool's coming out of their vagina, or they're like air coming out of it, stuff like that. So with Crohn's disease, when Crohn's wants to be ugly, it could be very ugly. And once you start having what we call fistulizing disease, then it's very bad. And these patients, they need surgeries, and then they're on antibiotics, and then the surgeries are often very complicated because there's so much inflammation, and then they can leak after, and you can't really reconnect them. So the goal is to kind of get to it before it gets that far, because it doesn't just, sometimes it can be aggressive where it just goes wild, but oftentimes it's like brewing and brewing and brewing, and then by the time you present with this, it's like, oh, where the heck have you been the past 2 years, right?
Why is it so hard to treat these kind of diseases? It seems like, from what limited knowledge most of us have when it comes to watching movies or hearing stories, it seems like we have a lot in that area to work with. Like we could go in and be like, you don't need that. Snip that out, put this together, you're good to go. Obviously, it doesn't work like that at all.
Yeah, you can't just, as of now, you can't do 3D printing of intestines. And, yeah, but maybe in 20 years we will. Elon Musk will work on something.
There we go.
I know. Tesla will come up with new colons. And
Right.
But no, I mean, first you got to understand, what's causing this? Ask me, what's causing it?
What is causing
We
this?
don't know.
Oh, great.
I mean, it's just, there's theories, right? Because it's an autoimmune disease, right? It's basically where your immune system has betrayed you. And now your immune system that's supposed to protect you is attacking your gut, right? There's thoughts that, there's a lot of study right now on the gut microbiome and everything. But, we have good bacteria and bad bacteria. Our immune system is supposed to attack the bad bacteria. But in cases of IBD, the immune system, for whatever reason, decides that it's going to attack the good bacteria. And then while it does that, it just continues. And it's just basically this immune-mediated response where your immune system is just attacking your gut. With UC, the immune system's attacking the colon. With Crohn's, it's attacking, anywhere, right? So basically, it's immune-mediated. It's an autoimmune disease, just like rheumatoid arthritis, lupus, psoriasis. It's immune. And anytime you deal with an autoimmune disease, there's no cure. There is just treatment. There's different medications where anti-inflammatory drugs, anti-TNFs, immunomodulators, immunosuppressant, because you want to basically either try to target and bring down the inflammation, or you want to hit the root cause, which is the immune system, by bringing down and telling the immune system, hey, take it down a notch, take it easy. Stop attacking the colon. The colon's nice.
It's there for it's your friend.
Just leave it as your friend. But then by doing that, then you're bringing down the immune system. So then you're at risk of infections and other things. So basically, there are theories that we know there's environmental factors, there's genetic predisposition, that's for sure. So there is genetic linkage, and then we feel that there could be also dietary causes. It's thought that certain people that have a diet that's like a lot of refined sugar, carbohydrates, and high animal protein are more predisposed.
Okay.
And again, there's environmental factors. I've actually seen it where patients develop COVID back when COVID bad, and then after COVID, boom, they develop Crohn's disease.
Really?
And it's not that COVID caused it. It's just that it just meant, and I had an attending back in fellowship. His name is Mark Piper. He's actually a good friend of mine. He always said this to patients, because patients always say, where did this come from? Why do I have this? And he always says, you've had this in you, and you've had this predisposition to developing it. And he goes, it's like a beehive that's inside, and the bees are in the beehive, and then they're just doing their thing, and then it just takes one thing to disrupt that beehive. And whether it's a virus or a bad infection or an emotional thing, like a sudden family death, right? So some stress response in your body that just disrupts this, and then basically the bees just go haywire, and that's the immune system. The immune system goes wild and it just starts attacking, and that's how IBD is. Basically, your immune system decides to start attacking your gut, specifically, kind of like with rheumatoid, your immune system's attacking your joints, right? With psoriasis, it's attacking your skin, etc. So that's basically what's happening. Your immune system is attacking you. Now, like I said, there's levels, and you may want to ask, what's worse, UC or Crohn's?
That would have been my next question. Yeah.
Yes, and that's actually a very common question. And it's not an easy answer.
Well, because it doesn't sound
opinion,
like
but in my opinion, remember how I told you earlier there's no cure?
Right.
Actually, I take that back. For UC, there is a cure. And just take a wild guess. What is the cure? I told you it's ulcerative colitis. It's just confined to the colon. What is the cure?
Well, it seems like you would not want to throw anything through there to make it worse. I don't know.
You remove the colon.
Oh.
Literally.
Okay.
So the cure for UC, which is, I make it sound like it's like a wisdom tooth. You're just pulling out a tooth. It's a big deal.
Yeah.
But like, if you want to get rid of UC, you get rid of the colon, right? Because when there's no colon, the immune system has nothing to attack.
What replaces the colon then?
Well, that's it. Yeah, you just basically, when you do a total colectomy, which is always the last resort, right? But back in the day, that's what happened. Over the past decade alone, we have so many new drugs. So many biological, blah. 20 years ago, we were limited. 30 years ago, we were really limited. 40 years ago, we were super limited. So that's why when I get these patients who are in their 70s and 80s, most of them, they've had so many surgeries, or they've had colectomies, and they've had like ileostomies or whatever. But basically, back in the day, they would try these drugs, mesalamines, and we know now those work for mild disease. But when it didn't work, if you had severe disease, then you end up just in and out of the hospital. You're pooping blood, and then you're getting infections, and then you're really sick, right? So then they just take out your colon. And when they take out your colon, you instantly feel better. Like, I've seen patients in the hospital that had fulminant colitis where their disease is so bad, and then when you remove it, because think about it, it's something that's like literally killing you. Yeah, it's just like inflamed. It's causing your whole body to just have this horrible reaction. You're getting infections. You can get blood clots, a lot of things, and you just yank it out, and then all of a sudden, you feel good, and you can live a normal life. You can, when you remove your colon, because the whole point of the colon is to absorb water, right? That's the main, and then to form stool and get stool out. The small intestine is where like the nutritional absorption and the vitamins, all that's happening. So when you remove the colon, you have one of two options. You have an ileostomy, which is basically the last part of the small intestine is brought to the skin, and then you have a bag, and then just stool forms, and you change it, and then you live. I don't want to say normal life, but it's different. But then better, you don't have that disease anymore. Or sometimes they could do something called a pouch, anal pouch, where they take a part of the small bowel, and it's a very complex surgery. That happens in multiple stages, but ultimately what they do is they leave a little part of the rectum, and then they take a part of the small intestine, and then they form like a new reservoir or a pouch that connects from there to the rectum. So now with that, the good thing about it is you don't have a bag anymore. You don't have an ileostomy. But then you could get, diarrhea, because think about it, your colon's not there anymore to like really absorb water. So you're kind of going a lot. Sometimes you can get pouchitis, and sometimes you can even get autoimmune disease that affects that pouch. So it's just like, it's not easy. But really, ultimately for UC, if you want to cure, the colon's gone. Right. But with that being said, it's not like, you tell, you have UC, let's take out your colon. Yeah. All right? No, so thankfully nowadays we have so many different things that we could do. There are so many drugs. We're not limited anymore. And that's why, unless you're someone who is just non-compliant, who doesn't want to see doctors, who doesn't want to be diagnosed, the moment, you start developing symptoms, when you get worked up, then we have good drugs for this. And the drugs, they vary from something as simple as mesalamines, which are anti-inflammatory drugs that work for mainly mild UC. We don't really use them much for Crohn's anymore. And then there's immunomodulators, which are like also medications that work on the immune system by modulating it, like azathioprine, methotrexate, and then we could use those. Those have been around. And then you have like the big guns, which are the biologics. I'm sure you see the commercials on TV.
Well, I wanted to ask you about that because I came across that term while I was looking into this a little bit, the biologics.
Yes.
And that kind of, I'd never, now when you say you've seen the commercials, I'm like, well, of course, that's where I recognize that from.
Exactly.
So what are they?
I'll tell you.
Okay.
So remember how we said this is an inflammatory condition,
Yes.
right? So how do you go about it? Either we said like overkill, you remove the colon, that's where you see it. That's like last resort, of course. Or the first step is you try to bring down the inflammation. So you use these anti-inflammatory drugs like the mesalamines, or you try to modulate the immune system.
Right.
So you use these drugs, azathioprine, methotrexate. And with those, they do have side effects like pancreatitis, bone marrow suppression, etc. Certain cancer, lymphomas, etc. Or the big gun stuff is biologics. Biologics are basically medications, and they're usually infusions or that target your immune system directly. So like anti-TNFs, anti-integrin. So those are drugs that are targeting the root cause. So because what is the root cause? It's your immune system, right? The immune system is attacking your gut. So then this biologic is going to target the immune system, like the T cells, what's driving this force. And it works by suppressing your immune system just enough to keep things under control. Now, there's many different biologics. There's a lot of biologics that are used for many autoimmune diseases. Like there's with us and the rheumatologist, there's a lot of drugs that intersect or overlap. Like, and I'm not gonna list the medications that are brand names, but we'll say like generic names. So like the anti-TNFs, like infliximab, those are used for like rheumatoid, and also we use them for IBD, Crohn's, and ulcerative colitis. Then there is ustekinumab, and that's also used for like psoriasis, okay? So with derm, and for ulcerative colitis and Crohn's disease. And there's so many other, I'm not going to list all of them.
Right.
But then there is some that are gut selective, vedolizumab, right, anti-integrin. So those are gut selective. We only use them for UC and Crohn's disease, and they work really well. I mean, the patient, it's a game changer for patients. And the way you do it is, first, you got to determine what they have. You want to rule out other things. There's a lot of things that mask IBD, right? First, you want to choose not IBS, right? But then you could, when it's IBD by doing the workup. The workup is going to be certain blood work. There's going to be scopes, colonoscopy. When I scope someone, I could usually tell just by looking what I'm dealing with. This is UC, or this is Crohn's, or this is just one of those weird ones, right?
Yeah.
Then you do biopsies, and the biopsies go in, and they look under the microscope, and they tell you, granulomas or ulcerations or lymphocytes and crypt abscesses, all these different terminologies that will kind of lean you more towards UC or Crohn's disease. But the good thing is, now a lot of those biologics, most of them work for both. So even if you're not sure that this is Crohn's or UC, chances are this drug is going to help, right? So the way you tackle this is it depends on disease severity. If someone has like mild UC, then you start with mesalamines. You put them on oral mesalamines and topical. Topical means like suppositories or enemas, and usually that will take care of the problem. And then you want to kind of follow them up, see how they're doing, how they're responding based on symptoms. Because the goal for every IBD case, whether it's UC or Crohn's disease, it's three things. It's three outcomes that we look for. Number one is symptomatic response, how they're doing symptom-wise. Number two is endoscopic response, which means when I scope them, how does it look? And number three, which is the ultimate, is histologic deep remission, which means that I scope you, you feel good before. When I go in, your colon looks healthy. And then when I take biopsies, the biopsies come back normal. That means you've achieved deep clinical histologic remission. That's the goal. Do we always hit that goal? No, but most times we do, especially now with these new drugs.
Yeah.
And literally, man, every 6 months, there's a new biologic coming out there.
Wow.
And it's like, oh my, it's overwhelming to keep up with that stuff.
Oh, I can't imagine.
But it's good for the patients because
Right.
there are options now, because now you don't just go for surgery, right?
Right.
And then surgery for UC, like I was back in the day, you're cured of the UC. Surgery for Crohn's is brutal.
Oh, I can't
because
imagine.
Think about it. I remember I told you
Yeah.
Crohn's affects everywhere. So basically, when do you do surgery for Crohn's? If someone has a bowel obstruction, an abscess, or a fistula, then the surgeon has to get in there, clean things up, and then they give them a bag or ileostomy, stoma. They wait for things to heal, then they reconnect it. A lot of times they start leaking, then they go back, abscess, this, that. Then you go in, you do more resection, then you do more resection. Next thing you know, they end up with short gut syndrome, and they're just miserable. So basically you want to leave surgery as last resort.
Yeah.
And a lot of these biologics, they prevent you from getting there. They really do. And it's key to tackle it before it's too late. Because once there is this unchecked inflammation and abnormal connections that formed, it's like, good luck, man. And again, man, there's levels to this. There's levels. There's like clear-cut, simple UC. There's clear-cut, simple Crohn's, where by simple it means easy diagnosis and then quick response. Because when you're treating, there's induction where you start with steroids to kind of bring down the inflammation, and then you want to put them on maintenance. Maintenance is what you're going to keep them on to just kind of control, because you don't want to keep someone on steroids long term. That's just never a good idea for any autoimmune condition. But you start with steroids, and then first you want to rule out infection, make sure that there's no infection, and then what I do with my patients, it's always a shared decision making. I tell them what your options are. I never just decide on my own. I give them suggestions. I say, in my opinion, this would be the best drug for you. In my opinion, this. Or there's a lot that they just go, no, I don't want this. I don't want something that's gonna alter my immune system. I don't want something that's gonna give me a small risk of like cancer or lymphoma. I don't want something that's gonna increase my risk of pneumonia and infection, because that's there. So then I tell them, it's not like we're doing this just for fun. It's not like, I just saw you at Safeway. I'm like, hey, I want to give you a biologic to go with that pineapple you just grabbed. No, I mean, there's a pretty good darn reason for me to mess with your immune system or bring down your immune system. Your immune system that you're so obsessed with has betrayed you. Literally, your immune system is attacking your gut. So it's either you let your immune system win and just take over, and then you're going to end up hospital, and you're going to end up with complications and all these different, what we call extraintestinal manifestations. Like I said, man, there's so much with IBD, where you get like uveitis, pyoderma, gangrenosome, biliary disease. That's when it goes wild. It just attacks your whole. And
it makes your job harder at that point too.
So I tell them, I say, your immune system is betraying you. So my job is to try to find a way where we can kind of get your immune system to calm down. So, for example, like I said, there are biologics that are gut selective that just work target gut. Usually, they like the sound of that. We do that, and if it works, great. But then every now and then, man, you get a patient that are just they're like conspiracy theorists and like big pharma's this. And yeah, don't get me wrong. I mean, I have my thoughts about but the thing is, these medications work. And you need them. And you have a real condition. This is not like something made up or fake news like Trump used to say. This is a real disease that is about to kill you, literally, and it can. So I say you accept the cards you've been dealt and we work together to control this, or if you want to just follow the natural approach, which I'm not against, but I'm against it when it's the only approach. I always tell patients this. I'm like, I'm not against alternative medicine. I'm not against that. But when it's used as complementary, So when you have severe Crohn's disease that's literally eating at your gut and you're forming connections between your colon and your bladder, guess what, man? Going and just doing meditation and smoking ganja, that's not going to take care of it. So I tell them, let's do this. You can go ahead and try the other stuff as complementary, and then we'll see how you do. As time goes on, we'll see. We can kind of try to get you off and see how you do, if you do okay. Because there are some patients that do well with dietary modifications, blah, blah. But when you have severe disease, we need to have like a serious treatment measure. But again, sometimes you get to them, and other times they're like, nope, I don't want to. You're pushing drugs down my throat. You're this, you and big pharma, blah, blah. And then I've seen it, man, where especially in fellowship, and then they go, and next thing you know, you see them in the hospital. They're hospitalized with a bowel obstruction, abscess, septic. It's just...
And sometimes you just want to say,
it's like, oh yeah, and you do.
I
told
you, sir.
I warned you.
Exactly.
I wasn't, out to get you. Your immune system was out to get you, and now it has won. And I'm sorry. And unfortunately, man, in medicine we deal with this a lot. I mean, my oncology colleagues deal with this with patients who have cancer who do not want chemo, and they go to these certain centers where they do these natural things. And again, I'm not against natural, as long as it's complementary.
Well, and as long as they're talking with you about it.
Exactly.
That's the thing.
And
right?
I'm very easygoing, man. That's my big approach. Is whatever. It's like I work with. I never force anything down anyone's throat.
Right.
And then in the end, even when I don't, if in the end, if they put their foot down, I don't want this. I say that's fine.
Yeah.
When you change your mind when you're ready, you let me know.
Yes.
And I lay it out and I tell them the risks, the benefits, blah blah. As long as the benefits outweighs the risks, then we're doing this for the right reason.
Right, every time.
So again, I'm not coming to someone who is just playing tennis and telling them, I'm going to put you on Entyvio. Why? Because Big Pharma. Oh yeah, my pockets are bulgy. Come on, man. So the thing is, again, so now another thing is when you have the diagnosis and hopefully you reach a diagnosis, you reach a good treatment plan, the patient's doing well, then we talk about maintenance, so which means you maintain them on this like biologic. A lot of times it's like every 6 to 8 weeks they go in for an infusion. Now we have other ones where they're injectables. The induction dose is an infusion. Then every 6 to 8 weeks they do an injection at home. It's just kind of like subcutaneous injection.
Right.
And then you follow them. You monitor like blood work. You monitor their inflammatory markers. There are stool markers that we look at. Fecal calprotectin that gives me an idea of how things are going. And then in terms of scoping them, so it's important that you keep a close surveillance on someone who has IBD because they're at increased risk of cancer compared to the average person.
Sure, of course.
So the way you do it, per the guidelines, and again, everything is case dependent, but per the guidelines, you get a diagnosis of Crohn's disease or ulcerative colitis. So first you diagnose it, then you work out a treatment plan, and then you hopefully get them into remission. Then once you got them in remission in terms of symptom-wise and everything and biomarkers and inflammation, then you set them up for another scope to confirm. It's called disease activity assessment to see how it looks now that you got them on this. If it looks good, then you've achieved as good as possible, hopefully deep clinical remission. Then you tell them, your next colonoscopy will be in 8 years. So that's so then you push them 8 years, assuming they're doing fine, right? And then after 8 years, you scope them every 1 to 3 years, depending on how they're doing, for surveillance because they're at increased risk of cancer. Especially you see there's increased risk of colon cancer compared to Crohn's, but both of them have an increase. So then you bring them, as opposed to, for example, let's say you're healthy, you do your screening colonoscopy at age 45. And I find nothing, then you're good for 10 years, right?
Right.
If, I find certain polyps, depending on the size of the kite, I bring you back in 3 years or in 5 years or in 7 years. But a patient who has IBD, their surveillance schedule is different. So again, 8 years from the date of diagnosis, and then every 1 to 3 years, depending on how they're doing. Someone who's doing great, who has mild disease, I push it 3 years.
Okay.
Someone who's like, I keep them close, right? Someone who I go in and I know they've had like fistulas before, they've had this, I keep a close eye. And in the beginning, what I do is I bring them in every 3 months to see how they're doing. I check, their basic blood work, make sure their liver enzymes are fine, they're not having a reaction to the medications. And again, one thing I forgot to mention, before you start these biologics, these drugs, you always want to make sure you check a TB test on them, that you do a hepatitis panel, you want to make sure that they don't have it. Because think about it, you're giving them a drug that's going to suppress their immune system. If someone has TB or someone has hepatitis B, now
you've just opened the floodgates.
Exactly. And then they could die from that.
Right.
So you make sure that they don't have that, and then you make sure that they're up to date with their immunizations, pneumonia vaccine, their flu shot. If they haven't had hepatitis B vaccine, you want to make hepatitis A. So that way you make sure they're protected, right? Because you are bringing down their immune system, and they are going to be at increased risk of opportunistic infections compared to someone who has their immune system intact, right? So you want to let them know to be careful, and you want to recommend that they're up to date with their vaccinations. And other things, you check their vitamin D level, because there's a correlation between low vitamin D and bad disease with IBD. So you want to keep an eye on that, and then you want to kind of keep that, supplement that. And with that being said, low vitamin D, with it comes early osteoporosis. So you do DEXA scans to make sure they don't have bone thinning. So like I said, a lot goes in with IBD. I'm telling you, we could go in for hours and hours, talk about it. But the basic gist is you diagnose it, you confirm that's what it is, not something masking it. Like, for example, NSAID-induced enteropathy. Some patients who are taking a lot of NSAIDs, Motrin, levoibuprofen, it could present that way, but it's not really IBD. And I've seen cases like that. I've had patients come to my clinic who've been labeled as Crohn's, and I go back to they're coming from out of state or whatever. I'm like, where did the Crohn's come from? And it's like someone diagnosed them with Crohn's, and it never was Crohn's, and they've been on a biologic, and I just tell them, hey, you do not have this. Trust me. We take them off, and now they're fine. So you want to make sure that it's not something that's masking it. But once you confirm the diagnosis, you come up with a treatment plan, then the goal is to just keep them maintained on something that works and keep a close eye on them. And a lot of them do well. Like I said, in this day and age, we have so many good drugs that work. But once in a while, Mark, you get a patient who just does not respond to anything. Right. And then they're just really bad, and they develop decompensated disease, fulminant colitis, and they end up needing surgery. Yeah. So,
that's always a last resort.
Exactly.
Right.
That's last resort. But thankfully, in this day nowadays, that really is a last resort. We're back in the 70s and the 80s.
That's the first thing you did.
It was the most common thing that was happening. I mean, these patients were their colon taken out. And but I mean, we were limited with what we had.
As a GI doctor, as we kind of wrap things up here, is there? I'll put you on the spot. Is there like one specific type of food you wish people wouldn't eat?
Yeah. So definitely high fat, refined, sugars, complex carbohydrates, high fructose corn syrup, this junk food that we have here in America on the shelves. Animal, I mean, I love meat and everything, but really, like, if you have a diet that's high in animal-based protein, that's not gonna be very gut friendly.
It really ups your chances for these problems.
Exactly. So that, man, I'm telling you, it's like high fat, animal protein, just bad sugars, high fructose corn syrup. Those are just they're not going to be very compatible with your gut.
Sure.
And it's going to lead to issues. And especially if you are already predisposed, whether genetically or environmentally, then when you do this, that's basically like going to be like the last straw.
It's the switch,
Exactly. And that's what's going to be like the trigger.
Right.
And that's going to boom. So that's why also with patients who do have IBD, it's important that they follow a good lifestyle.
I was going to...
No smoking. So smoking
of course,
is a big no-no, especially for Crohn's disease. You want to avoid animal proteins as much as possible, like, red meats. You want to avoid complex carbohydrates, high fructose corn syrup, those, really bad sugars, the bad carbohydrates. You want to focus more on, like, leafy vegetables, greens, like seafood, stuff like that. Yeah. So dairy is not going to be very, like, it creates a lot of bloating. So then we can follow something called like a low FODMAP diet, because there is also then an overlap between IBS and IBD that ends up like happening at some point. So then you want to follow a diet called the low FODMAP diet, avoid certain foods that increase a lot of gas and bloating and stuff like that. And then, believe it or not, even though a lot of these IBD patients do not have celiac disease, but studies show that avoiding gluten will help.
Okay.
So they do have gluten intolerance to a certain extent, even though it's not truly celiac disease. Okay. And again, celiac is a whole other topic that maybe one day we could talk about.
Well, I've got you scheduled in for a bunch of these, so so you're ready.
Please lose my number. But so that's the thing, man. I mean, honestly, it's just close follow-up. And then there is something that's extremely helpful. There's something called the Crohn's and Colitis Foundation. It's a website, and it's on there for anyone to access. And they have so many resources and for patients and patients' loved ones. And it links you with other patients who have Crohn's or UC. Yeah. And it has a lot of helpful information that breaks it down in a way that the layman, the average person, can understand. And it's also very important because a lot of these patients, man, like I told you earlier, they have a lot of psychological conditions, depression, anxiety.
Oh, I can imagine, though.
Yeah, because, I mean, especially when their disease is bad. Right. It's not, and they're miserable. And there's something that is also like a stigma where they don't talk about it a lot. And it's also like the sexual aspect of things. I mean, just how it affects them. And it's very sad because the patient who has really bad UC is having like a lot of diarrhea, who's having a lot of urgency, who's having like leakage, especially when they're in a flare or disease is not controlled. They cannot have a normal sex life. And it's important that we talk about these things.
Well, of course.
And that's something that's missed and the patient will not talk about because they're embarrassed, right? But it's important. And if someone's listening to me and are hearing this and you're a patient that is experiencing something like that, don't feel ashamed. You're going to your GI doctor and your GI doctor is not just there to deal with your to do your colonoscopy or throw meds at you or
Right.
be in bed with big pharma. No, your GI doctor is also there to listen to everything else, right? The psychological impact that has affected you with this
Right.
disease. Do not feel embarrassed and ashamed to talk about that. If you feel like, the sex life with your partner has been affected, then we could help guide them, send them to therapists. We could put them on antidepressants. I mean, we're internal medicine doctors in training, so we can address these things too.
Right.
Because I'm not just addressing your colon and your mucosal injury. I also want to address your psychosocial issues, your psychological, the manifestations that have resulted from this. So it's important that we kind of break the stigma and then we just talk about this. So as a patient, if you have really bad disease and if you're experiencing symptoms that are affecting you on a psychological level or on an intimate level, talk to your doctor about it. If they're a good doctor, most of the time they will hear you out and they will not dismiss you. And then, because who else are you going to talk to them about it? Sometimes, with their spouse, they're embarrassed. With their friends, they're embarrassed. Then that's why, like, a lot of times patients, then they come to me and then they want to talk about their poop or whatever and they get shy. And I'm like, listen, I always say this. I'm like, it's not like you're at the dentist and you're telling him this. That would be weird. I'm like, you're here. Go ahead. I don't care. Show me a picture of your poop.
Right.
Bring me your poop. Let's just splash it around. I don't care. So I tell them I make them comfortable to talk about whatever it is, because I'm there to help them and I don't judge, and they shouldn't feel embarrassed. And if you don't feel comfortable talking to your gastroenterologist about this, who are you going to talk to about that?
That's exactly it. Dr. Issam Turk, gastroenterologist at Monument Health. Buddy, thanks for coming in again. Like I said, we are going to have a lot more of these conversations,
Stop, man,
so get
please.
ready, all right?
It's the summer. I want to enjoy. I want to play tennis.
Well, we'll
I don't
see.
have time for this.
Thanks, doctor.
Thank you, man. Always good to see you.